السلام عليكم ورحمة الله وبركاته، وأسعد الله صباحكم بكل خير. سعادة اللواء بروفيسور الشيخ خالد بن علي آل خليفة، قائد الخدمات الطبية الملكية، قوة دفاع البحرين. أخواني وأخواتي السادة الحضور، يسعدني في البداية أن أرحب بكم وبضيوفنا الكرام خير ترحيب، متمنية لهم طيب الإقامة في بلدهم الثاني مملكة البحرين، وإنه لمن دواعي سرورنا أن نتشرف بمشاركتنا حفل الافتتاح هذا، والذي نظم من قبل وزارة الصحة بالتعاون مع المستشفى العسكري، معبرين فيها عن سعادتنا برعاية مثل هذه المؤتمرات الهامة، وذلك إيمانا منا بمدى أهمية رفع مستوى الوعي لدى العاملين الصحيين في هذا المجال.
Good morning everyone, and welcome to our distinguished respected chief guests and colleagues and friends to our first Bahrain Conference of Clinical Microbiology and Infectious Disease for the year 2012. It's a dream that comes true. First and foremost, I would like to thank His Excellency Major General Professor Khalid bin Ali Al Khalifa, Director of the Royal Medical Services and the VDF Hospital, and Her Excellency Dr. Aisha Mubarak, the Undersecretary in the Ministry of Health, for their valuable support towards a successful conference in the clinical microbiology and infectious disease in Bahrain.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. سعادة اللواء البروفيسور خالد بن علي آل خليفة، رئيس الخدمات الطبية الملكية بمستشفى دفاع البحرين، سعادة الدكتورة عائشة بعنق وكيل وزارة الصحة، الحضور الكرام من داخل وخارج مملكة البحرين. On behalf of the organization committee, it's my pleasure today to welcome all of you today to our conference in infectious diseases, clinical microbiology and infection control. We are extremely proud to host this event, which involves a large number of well-respected speakers from the Kingdom of Bahrain and other Gulf countries.
Going to talk about the epidemiology of methicillin-resistant staph aureus at Salmania Medical Complex, which is the main Ministry of Health, tertiary care, referral and teaching hospital. And here, just to show you the incidence of MRSA isolated at Salmania from 2007 till 2010.
Good morning, ladies and gentlemen. It's really my pleasure to be with you here in Bahrain, my second country. I always come here very frequently to share my experience from Kuwait regarding an important topic in which this BICMID, which I like the name really, BICMID, is going on for one day, talking mainly about bacteria and their problem with resistance. So, a bacterial epidemiology in Middle East region. My outline will be antimicrobial resistance in terms of gram-positives, gram-negatives, antimicrobial resistance in the region, GCC and others, and future perspectives. Bacteria are very smart. Antibiotic therapy, if indiscriminately used, may turn out to be medical flood that temporarily cleans. Your patient will get cured, hopefully, and heals, but ultimately destroy life itself.
Actually, I'm very happy about Dr. Hussain's question about what's antibiotic stewardship. We talk about it too much in infectious diseases, and I'll go through why we need it initially, and I'll go back and I'll give some important information about antibiotic resistance. So in conclusion, I said that antimicrobial resistance is increasing. It's a fact. We can't do much about it. Negative impact of resistance on clinical outcome with increasing morbidity and mortality. Many potential interventions that we can do actually. Do not treat non-bacterial infection or non-infectious disease actually. Do not prolong the duration beyond what's needed. Avoid prophylactic antibiotic unless benefit demonstrated with evidence of guidelines. use the narrow spectrum agent available. And antimicrobial stewardship program will have a great promise in changing this.
Most difficult, sensitive topic, most avoidable topic, which is combination of antibiotic therapy. Is it good or is it bad? When should we use it? I'll give you examples of giving a combination, not just based on Manaf review, just based on evidence. And then finally, we're going to just say this is what I think from the scientific point of view. So some examples. So example 1, when can you use beta-lactam? Two drugs from the same class as a combination.
It's very difficult actually to cover all the fungal diseases, the guidelines, the treatment and diagnosis in the next 25 minutes. I'll try to concentrate in what we are seeing, what's the epidemiology, and the guidelines for treatment of Candida first in the most common host, and then severely immunocompromised host. Despite we have good drugs available, they work very well, still we have problems with the incidence and mortality.
Now, talking about tuberculosis, it's an old disease and has no friends. All his friends are eradicated and eliminated, maybe controlled. Statistically proven that Bahrain is a health problem, and tuberculosis is a health problem in Bahrain, and we'll talk about it in the slides. What are the percentage and incidence and the incidence recorded in Bahrain? What are the burdens? Even if we have small numbers of cases or whatever the number we have, is it a burden on the general health of the community? And how do we prioritize the control of the disease related to the other infectious diseases?
I'll speak about MRSA guideline. And I heard the excellent presentation with bad news that there's a lot of MRSA in Bahrain. I thought that there was no MRSA, that I can skip all this presentation. You see, as a physician, as a nurse, as a doctor, you're not ID. What you need to know, two words, is it R and S, right? The bottom line. Resistant system. I don't need to think. This is not true for MRSA. So this is in our lab, respiratory culture. You can see here Staph aureus reported vancomycin sensitive. So we used to report only S. With a new guideline, the MIC itself has to be reported.
Otitis media is the most common bacterial infection in children. It's also the most common cause for doctor's visits, not only in USA, but actually everywhere. However, USA, they keep data. And the data there is 30 million episodes of acute otitis media annually. And the most common cause of antibiotic prescription, the talk of these sessions. Now, we know that there are lots of doctors who deal with otitis media, not only pediatrician. Indeed, many doctors see in the health centers, emergency doctors, they all see and treat otitis media.
In general, when we're talking about this special host, already there is if you appreciate what I mentioned earlier, already there are too many things that will interfere with the way this host is able to respond to infection. So the presentation of this particular patient when they come with infection sometimes may be very subtle. The signs and symptoms may not be very clear. Any change in body temperature, whether it's a little bit of a slight increase or a slight decrease, any change in the sensorium of the patient will need to make us very suspicious of a serious thing, and we need to act very quickly, because any delay in diagnostic or therapeutic thing will really lead to problems, as you have heard earlier about prognosis of these patients.
Well, I can promise in the next 25 minutes it's going to be less scientific, more just sharing a work that I've been doing since 2010, and then I'm telling a story. So it's going to be more of relaxing. Again, I'm not going to repeat the same thing about antimicrobial, but rather than talking about how can we solve the problem. All right, so my main talk going to be focusing in a three kind of strategic principle in addressing antimicrobial resistance. The first one would be, we're going to talk about some methods that will determine the initial empiric antibiotic choice. So some sort of methods will help us in choosing the right antibiotic. Second one would be, how can we optimize using the antibiotic once we have the initial report from the microbiology lab saying you have Pseudomonas, but until that point you don't have the sensitivity. So is there any way that we can play around in choosing the antibiotic. And finally, once you have the full report, you have the organisms, and you have the sensitivity, yet there are some problems that we might choose the wrong antibiotic.
It's a growing challenge for gram-negative multi-drug resistant bacterial infections, and here is the bag, I should say, of the multi-drug resistance that we're familiar with and we heard about. Actually, my main emphasis is going to be about ESBL and the multi-drug resistant Ebomani Pseudomonas aeruginosa. Starting with the MRSA and VRE, you've already heard enough about this today. This is some of the data showing how frequent it is. So I'm going to go really quick because that's a summary of all what we had this morning. And Dr. Afaf have nicely illustrated with the rates of MRSA. This is in North America, but you have more practical data from Salmania Medical Complex, exactly where you practice. The VRE issue, just a comment, when Jamila said we had one, actually we had several in Saad Hospital. And again, as Jamila said, it's based on the size of the hospital, and because of the high intensity of patients that I receive, we have a hospital of 400 beds and the ICU composed of 60 beds, kind of a skewed proportion relatively for a hospital of 400 beds. They have 60 ICU beds, but we're getting more VREs when the case was not the past 2-3 years before.
I wish to solve the issue of MRSA with vaccine, but unfortunately in June 2011, the clinical trial of Merck for MRSA vaccine development has been stopped, but still others are digging and trying to find a way forward. Until then, please work hard with and follow my senior colleague advice to compact bacteria and ensure there is no more development of multi-drug resistant microorganisms in general. This is our immunization schedule. Vaccination not anymore only for children. This is the old style thinking. It is for everyone. What we call in Arabic من المهدي إلى اللحد. So no age is. Yeah, through the life cycle, yes. So from the birth, you might require certain vaccination during your childhood, adolescent and adults, and elderly. And if you are among high-risk groups, you might need extra vaccination because your disease or you are high risk maybe by occupation. For example, you are a healthcare worker, you are exposed to infection, and you are at risk also of transmitting this infection.